morning, friends. We'll be starting with health programs in India. We'll be starting with Park 27th edition. First, we have National Vector-Borne Disease Control Program, under which we have diseases like malaria, filariasis, Kala-azar, which is a mosquito-borne. Oh, sorry, this is actually a sandfly. All other are mosquito-borne. Japanese encephalitis, dengue, and chikungunya. Again, here it is written all these are mosquito borne, while your Kala-azar, it is sandfly borne. Okay, under this National Vector Borne Control Program, we have three prevention strategies that we use, which is common to all the six. First is disease management. This is early case detection, complete treatment, referral services, epidemic preparedness. Okay, and rapid response. Then we have your prevention mein. This is integrated vector management, which this is an important short note for your exams. Then we have transmission risk reduction, like we use indoor residual sprays in selectively high risk areas, use of insecticide treated bed nets, larvivorous fish, anti-larval measures in urban area, and source reduction. And minor environmental engineering. It is simple that if there is any water collection, just throw it away. This is your minor environmental engineering. We have supportive interventions like behavioral change communication. What does this mean? For example, the community does not want to use your nets, for example, your bed nets, but you communicate them that this is very important and it is a very important measure to actually prevent these diseases, and it can save them money also. So it changes their behavior towards or changes their attitude towards these bed nets. Then we have public-private partnership and intersectoral convergence, human resource development like the laboratories, your drug disposing centers. Okay, first we'll start with malaria. The whole of the concept is ki this was the first disease that was considered for control and eradication. First, we have National Malaria Control Program in 1953. In 58, it was changed to eradication. In 2002, it was merged with it was named. Okay, and all the six diseases were merged together. In 2005, it became an integral part of your NRHM, National Rural Health Mission. Okay, then we have all these activities. We are going to just read them in repeat. So I'll just say that you take a gist of it and you can write it in all the diseases as like you want. First is policy making and guidelines, technical guidelines, planning, logistics, monitoring, evaluation. Now we have coordination through to the states via National Center Disease Control. Okay, National Institute of Malaria Research. We also collaborate with international organizations because they donate us medicines and test kits. For example, WHO. We have this Global Fund for AIDS, TB and Malaria, GFATM. Training and facilitate research and coordinate control activities. Organizations. So the head is your DGHS. Okay. And at the state level, we have National Vector-Borne Control Division, which comes under Department of Health and Family Welfare, and it is headed by a state program officer. Okay, so what does he do? He actually supervises, guides, and implements and sees the effective implementation of the program. Okay, what does the state responsible for? That the government supplies it the insecticides, the equipments, certain anti-malarials. Okay, and also they supply DDT and larvicides. Each state is has its own established society, that is State Vector-Borne Disease Control Society. At divisional level, we have zonal officers that are for technical and administrative roles, and they work under the supervision of senior divisional officer. At district level, we have chief medical officer and district health officer. At district level office, what they do? They are the key unit for planning and monitoring of the program. Then we have laboratories. Okay, now the laboratories have been decentralized and they have come in all PHCs. So the medical officer in the PHC, it is responsible for surveillance and laboratory services and also supervision of the spraying. Now the actual community outreach services like spraying or blood slide collection, case detection management is done by your multi-purpose workers and ASHA. Okay, now we have certain, this is also a short note, drug distribution center and fever treatment depots. It's for malaria. Okay, what is difference between drug distribution center and fever treatment depot? In fever treatment depot with dispense of anti-malarial drugs, also the blood sides are collected. Okay, so they actually distribute anti-malarial tablets as per national malarial elimination program schedules. Then we have urban malaria scheme. Its methodology is very simple: intensified anti-larval measures and drug treatment. Two things. Then we have an expert committee that has recommended that all of the urban areas with a population more than 1.5 lakh, or you can say 50,000, with slide rate positivity of more than 5%. Slide rate positivity means how many slides are positive from how many slides have been examined. Okay, now we come to the framework. So we can see it is from 2016 to 2030 and we have to eliminate malaria. So what we'll do, what are the goals? We'll eliminate malaria, means zero indigenous cases throughout the country. And we have to maintain this malaria free status where malaria transmission has been interrupted and prevent reintroduction of malaria. Okay, now this table is very important for MCQ purpose. Category 0, and it is not no state or UT, a union territory, has achieved this. It means zero indigenous cases of malaria. Okay, category 1 means annual parasite index. Okay, how many parasites have been detected in a blood slide? By how many blood slides have been examined? So if it is less than 1, then it is category 1. It is in elimination phase. It includes your Delhi also. Phase 2 is pre-elimination. It means that all the districts, for example, category 1 means all the districts have API of less than 1. Category 2 means some districts have API more than 1 and some districts have API less than 1. And category 3 means all the districts of the state have API more than 1. If all the states of the district have API more than 1, it means it is under intensified control phase. Okay, so then milestones, we'll skip it. Then focus on high endemic areas and tribal population, we'll read later. Now we have special strategy for P. vivax elimination. We have to eliminate P. falciparum because of its complication, but also vivax. Why? Because it is very challenging. How? P. vivax has hypnozoids. You know, in malarial cycle, okay, we have some hypnozoids that are sleeping in the liver, and after some time he can again relapse into vivax, into malaria. Okay, the patient, even after complete treatment, if these hypnozoids are not killed, so they will prolong parasites lifespan and difficult to detect. Now rapid diagnostic tests are available for P. vivax and P. falciparum, but rapid diagnostic tests for P. vivax are less sensitive, so it is difficult to detect. And radical treatment of P. vivax requires 14 days of primaquine therapy to kill the hypnozoids, whereas P. falciparum can be completed by 3 days. And P. vivax has longer incubation period. So P. vivax is important. So what we have done is, we have introduced bivalent RDTs, rapid diagnostic test. Bivalent to detect both P. vivax and P. falciparum. Now, ideally, we want the village to be as a unit of planning and implementation, but we right now have districts as a unit of planning and implementation. Now, each district has been said that they will classify their sub-centers and PHCs according to the API they have been reported. And this has to be evaluated every year. So, they can be classified as one with API 0, or 0 cases they have, no indigenous case, or API 0 to 1, 1 to 2, 2 to 5, or more than 5. Strategies. So we have these early detection and diagnosis, diagnosis and radical treatment, case-based surveillance, integrated vector management. We require IRS, that is indoor residual spray, LLNs, insecticide-treated bed nets, and larval source management. Epidemic preparedness and early response, monitoring, evaluation, advocacy, coordination and partnership, BCC, and program planning and management. With category 3, you may say there is massive scaling up of existing disease management and preventive approaches. Screening of all the fevers suspected of malaria, strengthening of intersectoral collaboration. Now this is important. We have mobile clinics or one-stop centers on fixed days in tribal or conflicted area to provide malarial diagnosis and treatment. This is important. Timely referral and treatment, establishment of robust chain supply management, maintenance of optimum level of surveillance using appropriate diagnostic measures, and equipping all health institutions. Okay. So, category 2. It is where API is less than 1 per case. Okay, has been reduced in some districts. That we use category 2. Then category 1. Okay, where we have actually less than 1 is the API. So means all the efforts are now to interrupt the local transmission in all activities of malaria. And we have to mandatorily notify each case of malaria from private or government sector or any health facility. Adequate surveillance, because now it is under control. So we require only surveillance. And if there is any case, we have to rapidly treat it and we have to interrupt all the local transmission. Okay. So early detection and treatment of all cases by means of ACD or PCD to prevent onward transmission. Okay, state and national level malaria elimination database, we have to maintain all the surveillance data, and we have national level reference laboratory. It is it serves two functions. First is the training part, and second is that it has to examine all the positive slides and a fixed number of negative slides to compare the true to confirm the diagnosis and cross-checking. Okay. Then we have category 0. No state has achieved this. So we have to detect and means here the malaria has been eliminated. It is not transmitted here. So we have to prevent any reintroduction of malaria. So we'll detect it immediately, notify all the cases, determine the local cause of resumption of local transmission, rapid curation, and maintain malaria free status in these areas. Surveillance. Okay, so active case detection. Okay, so it is by the multi-purpose workers and ANM. What they do, they go fortnightly and collect blood smears. Okay, this is active. Passive, where the patient reports to the health facility. Okay, it can be reported to the peripheral health volunteer, to the sub-center, malaria clinic, CHC, or any level of institution. So ASHA, what she provides, diagnostic services by rapid diagnostic test, and at PHC we have examination of blood smears. Okay, so ABR, absolute this blood examination, blood slide examination rate in our country is constantly 10%. Then microscopy. It remains the best method of diagnosis on account of its high sensitivity and specificity. It is also economical in facilities where large numbers of slides are being examined daily. Okay, so new norm for case management has been emphasized on the quality of care. So what are the new norms? We will use rapid diagnostic tests and artesunate combination therapy. Okay, and we have already discussed, we have introduced bivalent RDTs. Now parameters. We above discussed this ABER. What is this? Annual blood examination rate. So when we talked about above, we talked that there is a national laboratory that examines all the positive slides, also certain negative slides, to maintain the standard. Okay, so they examine this as control, which is taken to be 10% for the whole country, and where there is more prevalence of malaria, more than 10% slides of the population will also be examined. Okay, then we have annual falciparum rate, slide positivity rate, and slide falciparum rate. General surveillance we have already done. Now case management we'll have already read in previous chapter. Now we'll come to integrated vector management, which is very important question. So what it is: biological, chemical, and environmental interventions of proven efficacy in areas. So what will we do? We integrate by using identical vector control methods to control what? Malaria and leishmaniasis in rural areas, and malaria and dengue in urban areas, to achieve cost effectiveness and synergy. So what we'll use? We use three things in this. First is measure to control adults. We have indoor residual sprays. Then we have second, anti-larval measures, chemical, biological, environmental, we'll read later. Then third is personal protection using bed nets, including insecticide treated nets. So National Malaria Control Program is currently using IRS, indoor residual spray, and primary method of vector control in rural settings, and anti-larvals in urban areas. Okay, the village we already discussed, it was supposed to be the unit of intervention, but it is not possible. Therefore, some district is used as a your unit of planning and implementation. Okay, villages which have at high risk. Okay, so they have to be protected by IRS and insecticide treated nets, and the coverage should be more than 80%. Okay. Now we have population living in areas which are under intensified control or API more than 5. So they have to be covered by linens, and population living in endemic areas with registering of API more than 2 have to be covered with conventional nets treated with insecticide and IRS. Okay, IRS is a still preferred method for vector control in areas which have very hot summer, or where these nets are not acceptable to the population. Okay, for malaria we have to know that DDT is the insecticide of choice, but where vector has shown resistance to DDT, we may use malathion and synthetic pyrethroids, and 2 rounds of spraying is done for DDT or any insecticide that we are using. Then we have malaria paradigm and ecosystem. So it is presently malaria is highly concentrated in few forests or tribal stages or area. So northeast is very specific here. Why? Because of difficulties in implementation and monitoring. Why? Because we have inaccessible terrains. People are always moving. Tribal areas, I mean. Poverty, inadequate clothing, outdoor sleeping habits, forest-based economy. Predominant species in tribal area is P. falciparum, and is known to cause severity and lead to mortality if timely treatment is not provided. So we have tribal malaria action plan. Again, strengthening surveillance, provision of hamlet-wise ASHA instead of village-wise. Hamlet-wise means whatever herd in the herd, or you can say group in there moving. Wherever engagement of ASHA is not possible, we can use Anganwadi workers or any volunteer in the village. Okay, then we have already discussed mobile health services, involvement of locals, okay, NGOs, strengthening PSCs, quality microscopy facilities, diagnosis and treatment. And what is important is RDT, because on the spot we can give them radical treat. On the spot we can detect if there is malaria, we can detect the species if it's vivax or falciparum, and we can give species specific radical treatment to all positive cases of malaria. If any serious case is there, we can refer him, ensuring free transport services, follow-up, mass screening of migrants wherever necessary, integrated vector management, social marketing to increase usage of bed nets, minor environmental engineering like sanitation, and regular efficient supply chain management. Now we come to BCC. You'll read BCC everywhere. It's a very general term. It motivates individuals, family, and community to change their inappropriate, unhealthy behavior or to continue a healthy behavior. So many people do not like to use bed nets, but we should motivate them. We should encourage them, and we should give them information that how it can be very beneficial for them to use it. Okay. BCC is directed at early recognition of signs and symptoms of malaria. They should know what are the signs, when they should seek the treatment or they should seek the early treatment, adherence to the treatment, ensuring protection of children and pregnant women, use of ITNs and linens, and acceptance of indoor residual spraying. So June is the anti-malarial month. This is prior to the onset of monsoon and transmission season. Okay, so these are all the malaria related facts. We won't be reading facts. We have then elimination of lymphatic filariasis. Okay, so elimination of lymphatic filariasis ceases when the public to be a public health problem when number of microfilarial carriers is less than 1%, and the children born after elimination of filariasis are free from circulating antigenemia. Okay, no antigen is found in them, or you can say presence of adult filarial worm in human body. So this is actually the elimination definition of filariasis. So how we do it? By annual mass drug administration. This is important. Okay, so we'll give massive drug administration. We have 3 drugs we'll read later. They are for 5 years or more to the eligible population, but whom we will not give these drugs? Pregnant women, children below 2 years, and seriously ill persons to interrupt the transmission of disease. Home-based management of lymphedema. Okay, and we have to increase upscaling of hydrocele operations in identified CSCs, district hospital, and medical colleges. Okay, earlier MDA was only DEC, but now it has been increased to DEC, diethyl carbamazepine, and albendazole, ivermectin. Sorry, this is the regimen we use. It is a triple regime. So we have ivermectin, DEC, and albendazole. Okay, 5 years or more. And what else we have? We also we have seen this. We are upscaling foot care and home-based foot care and hydrocele operations. Now this is a PG question. Transmission assessment services for filaria. Okay. Okay. Now if you read this example, if we demonstrate people how to wash their foot to maintain hygiene and prevent secondary bacterial infection who have chronic lymphedema. For example, the person already has chronic lymphedema, but now we tell him that he should wash his foot and maintain hygiene of his foot so does not have secondary bacterial infection. This is your tertiary prevention example. Okay, and how much population should be covered for mass drug administration? 80%, 5 to 6 year, which reduce microfilarial load in the community and thereby interrupting the transmission. Then we come to Kala-azar. Okay, so again the same as strategies. We have to increase case detection, complete treatment, and this is important. This was also a PG question. RK39 kit. It is a rapid diagnostic kit. It is for Kala-azar. Okay, and we give oral drug miltefosine for treatment. We have to interrupt the transmission through vector control. Now we have replaced DDT with synthetic pyrethroid. Okay, to eliminate sadfly as the insect is becoming resistant to DDT. Communication for behavioral impact, again your BCC and intersectoral convergence. Capacity building, monitoring, surveillance, evaluation, and research guided guidelines on prevention and control of Kala-azar. We have active search case. Okay, it is also fortnightly, just like a malaria. We go from door to door search. Okay, all the volunteers go. So, so case definition conforming and they maintain themselves to the case definition of Kala-azar and post Kala-azar dermal leishmaniasis, and they take them to treatment centers for definitive diagnosis and treatment. Every patient who is being treated at the hospital will be given 500 rupees for Kala-azar, and 2000 if he is going for post Kala-azar dermal leishmaniasis. Strategies, they include rapid develop diagnostic kit. We have already seen that by ICMR. We'll also give single dose treatment with liposomal amphotericin B, which is given IV, 10 milligram, 10 milligram per kg. Okay, body weight. It is to reduce human reservoir of infection. Then we have Japanese encephalitis. It has high mortality rate, and those who survive, they have very high neurological complications. So in question stem, generally what states they give? Bihar or West Bengal. As JE is an outdoor rester, IRS is not effective. As there is no specific cure for the disease, so with the both here is early case management is very important to minimize risk of complications and death. And this JE vaccine is also important for children 1 to 15 years of age. Okay, then we have your other prevention strategies, that we should keep pigs away from the human dwellings, or we should in pigsties during dusk at dawn, we should keep them in cage for dusk at dawn, which is the biting time of vector mosquitoes. Use of clothes which cover body fully to avoid mosquito bites. Use of bed nets is very important precautions. Since early reporting of cases is important to avoid complications, community is also instructed on about the signs and symptoms of disease. And we use Malathar for outdoor fogging as outbreak control in the affected areas. Then we have dengue. We remember Delhi. Okay. So since early reporting and case is crucial to avoid any complication and mortality, just like your Japanese encephalitis, we also give community full information about signs and symptoms. You all have read, or you must have heard on radio, whenever monsoon season is approaching, they give you all the information about dengue. Okay, their health services at health centers, hospitals. We alert hospitals for adequate arrangement for management of dengue hemorrhagic fever, and we tell them to empty a ward just for dengue patients. We have 14 Apex referral laboratories. What we use? We use functional IgM capture ELISA. Okay, but we also have new case like NSI. It is ELISA based only, but it can detect your dengue from day 1 of infection. IgM capture ELISA only detects from 5th day. Okay, so how do we prevent or control? Monitoring. Then again, we have all these surveillance, case management, vector management, outbreak response, capacity building, BCC, intersectoral coordination, monitoring and surveillance, supervision. Sorry. Okay. So, then chikungunya. It is also it is a re-emerging illness. It is debilitating, but this is not fatal. Not fatal. Now, since chikungunya, dengue, they have same Aedes as a vector, so more or less their vector control is also same. So this was all about National Vector Board Control Disease Control Program.